Hello, everyone. Tonight, I want to start off by covering Domain 5 of the CCS exam while you all are continuing to enhance your ICD 10 PCS skills with the I think it's about 200 scenarios that you are coding, and I will allow time for you to finish them or continue to work on them tonight. I want to continue talking about the different domains because number one, I don't want to run out of time. So, in case you are keeping track, we've covered domain 1, 4, and now 5. And then I will go back and do 2 and 3. Okay, so domain number 5 is actually very small, but I feel like it's more complex because it's terminology that you've heard of, you may use, but don't really know the background of these concepts. So domain number 5 has 4 tasks: distinguish between the types of EHRs, demonstrate a basic understanding of encoding and grouper software, exhibit an understanding of CAC, computer assisted coding, and its impact on coding, and then ensure compliance with HITECH guidelines. So I believe it was domain 4 where they talked about HIPAA, privacy and security. And so that web page that I gave you actually has a link for high tech, and I would highly recommend that you take a look at that link. So let's dig in. So we're going to start with electronic health records, also known as EHR. And one of the things that I think is really important to note regarding an EHR is that it's actually more than a digital replacement for a chart, right? The electronic health record provides us with real time, patient focused, patient centered record that makes information instantly available to authorized users, right? Now, one of the things that I think is important to note is that many people across the enterprise, the healthcare enterprise, may have access to the record, but the extent to which an individual has access is going to be based on their role, right? So it's like user based access, role based access. So someone who is working dietary, they will not have access to the entire medical record because really their focus is on what orders have been placed from a dietary perspective. So another thing that I really love about the EHR is, like, think about this. So it's Monday evening, and let's say you go to the emergency room tonight, and then tomorrow you see your primary care physician. An effective EHR would allow both providers to instantly access your records, your labs, your diagnoses, treatments, right? Back in the day, we used to have to wait on fax paperwork, and that could take a long time. So let's now talk about the different types of EHRs. And one of the things that I was careful about in terms of preparing the content for Domain 5 is I didn't want to just say, okay, it's only 4 tasks, it's very basic, when in actuality, it's a little bit more complex, right? So there are different types of electronic health records. Number one, we have a standalone. And standalone are systems that are used by a single provider, a small clinic. They're not designed to share information easily with other facilities. So, for example, a private practice might have a standalone system that houses just their own patient records. In contrast, an integrated EHR can link multiple departments, providers, facilities that are a part of a network. Hospitals often use integrated systems where inpatient, outpatient, radiology, lab can all document into one shared patient record. What this does is improve care coordination significantly, right? One of the things that drives me, it grinds my gears, is to be sitting in front of a physician for care and, telling that provider that you've had XYZ done and they can't access it. It delays the um, the care that is provided. And I would like to see just one health record that everybody uses, but that's not going to happen. All right, then we have cloud based EHRs. Those are hosted online as opposed to like a physical server. And these are popular because they allow remote access for services like telehealth, home health, or multi site organizations. So, as it relates to the EHR, understanding the structure is critical, or as it relates to the CCS, I should say, and the EHR. Understanding the system structure is critical because it affects how you actually access the record to code as well as audit services. So there are features of the EHR that actually help coding and documentation workflows. So, first, we have templates. Templates ensure that providers are consistently documenting required elements, right? So, like the chief complaint for the visit, exam findings, etc. For coders, templates help us locate critical details faster. Then we have drop down menus. Drop down menus allow providers to select specific diagnoses and procedures, which can reduce spelling errors or vague terms. One of the things that I was surprised about is the number of misspelled words in medical records when they were handwritten back in the day or actually typed. That just lets me know, physicians are human just like me. Next, you have those, they call them real time alerts, but we can flag where there's missing or conflicting information, which helps to prompt corrections being made before the record is finalized. So, for example, an alert could warn a provider that they document a diagnosis that lacks a corresponding treatment plan. We also have audit trails, and this is something that hopefully, when you did your review of the HIPAA privacy and security laws from Domain 4, that you learned that every time a record is accessed or edited from a compliance perspective, audit trails actually helps to investigate who made changes and when those changes were made. And today, even though we're using electronic health records, many systems have the ability for you to kind of hover over the text to help you see who actually created that actual content. And so think about this. If you find, like, let's say you're auditing, if you find inconsistent dates of services across different notes, you can check the audit trail to see if a correction was made or if it's, it's just a documentation error. So there are definitely benefits of EHRs. I think many of us thought, oh, electronic records were going to solve all the problems. And unfortunately, it solved some problems, but then introduced new ones. So some of the benefits, improved accuracy because having legible, structured digital records significantly reduce the documentation errors that were caused by handwritten notes, misinterpreting what the doctor was saying. But second, we get faster access to patient information, right? So whether it's labs or imaging results or past visit notes, clinicians can pull up what they need in seconds instead of requesting physical charts. I remember being at the hospital um, trying to locate medical records, trying to locate um, a single piece of paper from the medical record. So, definitely, it has decreased the old school record or document search. Thirdly, EHRs are more efficient. Providers spend less time searching for information as long as they've been trained properly. And coders benefit because complete and structured documentation means faster code assignment. Before EHRs, and I remember this like it was yesterday, locating the patient's allergy could involve multiple phone calls, fax documents, and now one click we can see the allergy listing instantly. So efficiency and access improvements are often a concept that you'll need to understand for the EHR and the CCS exam. Challenges. Well, number one, oh, good old copy and paste. This is a major risk. Sometimes providers reuse text from previous notes without updating it, which leads to inaccuracy. So, for example, a copy note may falsely state that a patient still has a urinary catheter today when it was removed days ago, which has an impact on care as well as could impact coding accuracy. Alert fatigue. This happens when providers see too many system alerts. Over time, they may ignore them even when there's something critical that we need to be aware of. Then we have the misuse of templates that can cause generic documentation that lacks the specificity that we need. For example, a provider might document chest pain without elaborating on it, which leads to uncertainty when it's time to code the encounter. I will say that clinical documentation improvement efforts have definitely helped with this, but it has not eliminated it. So, one of the things that I would um, tell you to ask yourself is how can we identify and educate the continued flags that we're having to do to help decrease the number of times that we have to flag? All right, so EHRs and the coding workflow. So, as coders looking at medical records, we navigate multiple sections of the EHR, right? Progress notes, surgery reports, imaging interpretation, lab results, and that EHR acts as the single source of truth for code assignment. Knowing how to properly navigate the EHR allows us to verify diagnoses, clarify procedures, and ensure that that documentation supports billing. One example that comes to mind for me is if a discharge summary documents pneumonia, but the radiology report doesn't confirm it, we may need to query the provider for clarification. On the CCS exam, they may present scenarios where multiple parts of the document, medical record, needs to be reviewed to determine the correct diagnoses. All right. So now that I've talked a little bit about the EHR, I wanted to take a moment to stop and do some questions. So this first question is what which of the following best defines an EHR? So the major components that are typically found in an EHR, you're going to find things like the patient demographics, progress notes, medication lists, lab imaging results, as well as a problem list. And so, which of the following best describes the EHR would, of course, be C, a digital version of a patient's medical record in real time. And so that's letter C. All right, the next question. Which type of EHR is most likely to offer remote access to patient records? And we talked about this as well. And so the answer would, of course, be B for cloud based records. One of the things that I do want to remind you about is that on the CCS exam, the questions are not going to be what do I want to say? They're not going to always be a single sentence where you're being asked to test your knowledge of something. The question could be multifaceted, where you're being tested on knowledge, comprehension, and the ability to apply, analyze concepts. All right, so for here, be cloud based. All right, our next question. Which of the following is not a core feature of EHR systems? And um, this one is pretty easy, right? Because the question is asking you what is not. And so you have to figure out what is to help you figure out what is not. And if you said C, grouping reimbursement codes, then you are correct. And notice how the question says, which of the following is not a core feature of EHR systems? All right, next question. One advantage of an integrated system is, and if you said B, enhance interoperability across departments, you are correct. Next up, which of the following EHR features supports accurate coding? All right. If you said A, drop down menus for procedure selection. But of course, we need that specificity because it is so very, very important. Next, what is one risk associated with EHRs and documentation quality? And we literally just talked about this. All right. If you said B, alert fatigue and over documentation, you are correct. And this question asks about a risk. All right. Our next question. Which of the following is least likely to be found in an EHR system? All right. If you said C, medical device instructions, you are correct. All right, next question. EHR audit trails are useful for, and we just went over this. This is that situation where the patient or where someone is accessing the records multiple times. The audit trail allows us to see how many times they were in that record, who documented what. Were you supposed to be in that record? I think that's also something that's worth noting because sometimes people, oh, they get like, oh, I want to go check out such and such, my neighbor, or some VIP that was admitted to the hospital. One of the things that they really try to do when a VIP is admitted to the hospital is that they will register them under a different name. They'll come in um, a back way into the into the hospital as to minimize us wanting to look at their information. So monitoring those patterns is the correct answer. All right, next question. Which of the following statements is true? All right. So if you said EHR support coders by organizing clinical data, that is correct. The other thing that I want to just call out is that no one has the questions to the actual CCS exam. And so your goal should be to understand the content so that you can apply it. All right. And I think this is the last question. Which of the following is a disadvantage of EHRs for coding professionals? And this one is, I don't know. I could see where you would say two of them could be a disadvantage. I would say particularly B and C. But the best answer is multiple documentation tabs and screens because it could make the process a little bit more challenging because you're having to look in multiple places instead of one. All right. So that was yep, that was the last question. And so now we're going to go on to task number 2, which is demonstrate a basic understanding of encoder and grouping software. So I think in our time together, we've talked a lot about the 3M coding system, but there are actually um, more software programs out there. So I'm thinking, let's see, Nuance Clintegrity is a type of encoder software. Um, I think True Code is a company that still has a product, and it's True Code is TRUCODE. Okay. So in Blackboard, I did want to call out that I did provide you with some information on um, encoders. So make sure that you check that out. Again, I just want to overemphasize the information that I and resources that I have provided. Those are just not something that are nice to read. It's something that you will need to do so that you can have as much knowledge as possible. All right, so let's talk about what are encoders. So, encoders are electronic tools to help us assign the most accurate diagnoses and procedure codes. Encoders guide us through what are called coding pathways. They're designed to help support compliance with the coding guidelines. So for example, you could be using an encoder and you type in myocardial infarction, and the encoder is going to ask you, is it a STEMI or a non-STEMI? One of the things that we talked about here is being encoder dependent, and one of the things I think is important for you to know is that while encoders streamline the coding process, they enhance accuracy and productivity, they don't replace coder judgment. You still need critical thinking to interpret the documentation correctly. Now, there are a couple of different types of encoders. I like to group them into logic based and knowledge based, but I think they have more formal names. So, logic based, I like to say, is like code book logic. It actually guides you through like yes, no questions or pathways, which leads you to the code. But I think it's worth noting that you're in the driver's seat when it comes to the actual code selection. Automated encoders, they scan the documentation and suggest codes based on natural language processing, also known as NLPs. And so you heard me say logic based encoders and knowledge based encoders. So I want to call out the difference between the two. So logic based uses logic to guide you to get to the code. Knowledge based encoders, you have to actually, I think you're more in the driver's seat because you have to use your knowledge. Then integrated encoders work within a EHR or computer assisted coding, which provides seamless code selections during the documentation review. And again, logic based encoders can ask you a question, right? So it may say something like, okay, you put in pneumonia. Is this pneumonia community acquired or hospital acquired? Which helps again support the coding process. So, one takeaway that I want to make sure that you have an understanding of as it relates to encoders is that encoders assign diagnoses and procedure codes. That is very important because I want you to have a distinction between um, encoder versus a grouper. So, groupers actually take the codes that you have assigned and classifies or converts them into groups. And so groupers can help us get the DRG, which, as you know, is used for inpatient coding, or APC, which is used for outpatient care. And let me just call out one more time that there is also an APR DRG, and that is generally for like Medicaid inpatient services. And so I just want you to keep that in the back of your mind. Okay. All right. So um I think that's all I want to say on what is a grouper. But I did want to talk about, the encoder grouper in action. And again, you've seen um, you've seen this, right? So the patient has pneumonia. The encoder assigns the J18.9, and then the grouper then goes ahead and assigns the MSDRG of 193. All right. So grouper software uses like a defined set of codes combined with like patient demographics to assign the correct reimbursement classification. And you may recall that from an inpatient perspective, you saw me enter in the discharge status first. Discharge status, also known as the discharge disposition. Then I entered in the admitting diagnoses. And recall, the admitting diagnoses does not impact the MSDRG, but it is required for the UBO4, which I talked about in domain number 4. So with the encoder, right, you put in the principal diagnoses, the secondary diagnoses, and those secondary diagnoses could impact reimbursement. So think about the patient who has pneumonia and nothing else. That's going to be grouped to DRG. I think it's 195 that was on that screen. I think that's the number. But when you add in secondary diagnoses that the system recognizes is a CC or MCC, then it shifts to a higher paying MSDRG. So coding quality impacts grouping, right? And therefore impacts reimbursement and compliance outcomes. And why does grouping matter? I think I want to just end here by saying accurate grouping ensures that we get reimbursed fairly based on the resources that we use to care for our patients. And coding errors that lead to overpayments can trigger audits, penalties, and based on the False Claims Act, the hospital can have to repay money. And so overpayments can do that, right? But if you undercode, it will result in a financial loss to the organization. And I think people used to think that undercoding was like, oh, it's okay, right? but undercoding shows that there is a misunderstanding of the rules, just like overcoding does. All right. So let's look at some questions. And so the first question is, what is the primary function of an encoder? And I want to just reiterate, very important for you to understand the difference between an encoder and a grouper. Okay. So what is the primary function? And if you said B, assign medical codes using logic or automation, you are correct. All right, the next question. What is a grouper primarily used for? And this should be pretty simple for you to call out. So remember, encoders assign the diagnosis and procedure codes. The grouper groups them together so that we can come up with our DRG, inpatient, APC, outpatient. So the correct answer is B. One of the things I'll just call out right here for you to remember, we can have unlimited APCs on our claims, but we can only have one APC or one DRG per admission. All right, the next question. Which of the following best describes a logic-based encoder? And this should be pretty clear because I talked about this multiple times. And if you said B, ask decision-based questions to guide coding, you are correct. All right, next up. Which of the following correctly matches the software with its function? So which of the following correctly matches the software with its function? Grouper assigns procedure codes. No, grouper assigns procedure codes and diagnosis codes. A grouper does not create clinical documentation. Encoder assigns the DRG. No, the grouper assigns the DRG. So the answer is C, encoder, assist in code assignment. So let me just reiterate this again. For this CCS exam, you really have to know the content so that you can apply it to the question that is presented to you. All right, next question. Why is understanding grouper software important for coders? So, why is it important for coders? And as a reminder, they're always going to give you two answers that look correct and two answers that are just flat out wrong. And so, why is understanding grouper software important for coders? Grouper, the grouper is tied to reimbursement. Encoder, coding. Grouper, grouping the codes together to give us that APC or DRG, which is tied to reimbursement. All right, next question. What type of code would most likely be used by a grouper? What type of code would most likely be used by a grouper? Grouper takes the codes and groups them together for purposes of reimbursement. So, first things first, we have not talked about RX Norm or SNOMED. So, you can eliminate those two. And then HICPICS level 3 was deleted. Oh my gosh, I have to Google it to see. I want to say 2010. It's been a while since HICPICS level 3 codes were eliminated. We no longer have them. We only have level 1, which is CPT, and then level 2, which are the HICPICS or national codes. So the correct answer is B, ICD-10, CM, and PCS. All right, the next question. Encoders may be integrated with, and again, now, of course, on the exam, it's not going to be this simple. I like to just remind everyone that what we're covering, what's on the AHIMA content outline, is the floor of what you need to know and definitely not the ceiling. And so if you said A, C, you are correct. All right, next up. Which of the following is most likely to influence a DRG assignment? Which of the following is most likely to influence the DRG assignment? And again, I made these really simple. And of course, the answer is the principal diagnoses. So that would be letter C. Couple more here, and then I will do a break. When would a coder typically use a grouper? When would a coder typically use a grouper? If you don't know anything else tonight, I'm sure at this point you know Encoder assigns the diagnoses and procedure codes. The grouper groups together the diagnosis and procedure codes. So, as you have seen multiple times, with me doing demonstrations of APC and DRG, you know the answer is going to be B, after assigning diagnoses and procedure codes. All right, and I think this is our last scenario. The output of the grouper is 2. And if you said C, you are correct. So I want to just reiterate that I provided you with some additional resources that are inside of Blackboard for this topic. I would highly recommend that you are um, reviewing those resources, saving them, because once this review is over, I don't know how long you'll have access to the system. So now is the time to download them. All right, so let's take a 15-minute break. I will, of course, play music for 10 minutes. And when the music stops, you know that the break is over. All right. We are back for our Domain 5 review, which focuses on information technology. And now we are going to go to task number 3, which focuses on ensuring compliance with the HITECH guidelines. So I think it's important to first just spell out what is HITECH. So HITECH stands for Health Information Technology for Economic and Clinical Health Act. This was passed in 2009, and the goal was to promote the adoption and meaningful use of EHRs, simultaneously strengthening the HIPAA privacy and security provisions. So, as I mentioned before, HIPAA was part of Domain 4, the privacy and security, but inside of Blackboard, you do have the links to get you to the page and to get you to the page for purposes of seeing all of this information. Please just really understand that that content outline that's giving you all the different tasks, you owe it to yourself to review the information. Because let's say you get a coding question that is like so difficult, why not let um, these questions be the easy ones that you can get through. The other thing I want to mention is that high tech changed how healthcare organizations manage, secure, and share patient information, but it also introduced some significant penalties for breaches. Last week, I was at the Healthcare Compliance Association HCCA conference, and security breaches, and cyber attacks continue to be on the rise. So there were some major components of the HITECH Act. The first was meaningful use. Meaningful use required that providers had to demonstrate that they were using EHRs effectively to improve patient care and not just for administrative tasks. The breach notification rule, healthcare entities has to notify patients and regulators if unsecured PHI or protected health information is breached. And there are also some civil and criminal penalties. And these are the fines that are associated with HIPAA violations. They increase substantially under high tech. And I will also just kind of call out that high tech did offer incentives to get organizations to convert from paper to electronic. All right, so what are some of the impact on health information management and coders? So, coders play an active role in high tech compliance. Why? We have to safeguard printed or downloaded records. We have to use secure passwords and not sharing your login credentials. Now, of course, if you are communicating with the IT department, they may ask you for some information, but one of the things that they always do is make sure you are you. And let me just tell you that phishing and all of that is on the rise. So it's so very important to protect patient information. Always reporting suspicious access immediately. And then ensuring that what you code is based on documentation. And if you were on site, ask yourself this question. If you saw somebody over there printing dozens of patient records without a clear reason, what would you do? Say something. You see something, you have to say something, right? But first, you got to check it out. So, there are many examples of breaches related to high tech. We always hear about the lost laptops. We always hear about unauthorized faxing. I would say lost laptops more than anything else. And so there's a couple of things you need to know about a breach. So, number one, if a breach occurs, there are strict rules for notification. So, breaches that are affecting 500 or more individuals have to be reported. They have to be reported to the patients that were affected, as well as the Department of Health and Human Services, the Office of the National Coordinator, ONC. as well as major media outlets if required. So, if an unencrypted laptop with PHI is stolen, that triggers a reportable breach. But listen, not every incident involving PHI is a reportable breach. One of the things that we can do in terms of seeing if something needs to be reported is we can do a risk assessment, right? And the risk assessment can consider the nature of the PHI that was involved, who actually received the unauthorized information, whether the PHI was actually viewed or acquired, and then the extent to which the risk has been mitigated. I do want to call out that the government established this tiered penalty system based on an organization's level of negligence. And the penalties range from like $100 per violation up to 50,000 per violation with a maximum, and I think it's like 1.5 million per calendar year. And so a hospital that knowingly ignores HIPAA security faces significantly larger fines than one that made an honest mistake but took corrective action. So again, just want to just remind you um, that high tech builds on HIPAA, right? HIPAA established the privacy and security rules. High tech expanded the rules to cover electronic records and increase enforcement and those fines. So think of high tech as giving HIPAA more teeth, right? Stronger penalties, stricter expectations in this digital age that we are operating in. All right, now it is time for some questions, and I'm pretty sure you know these answers. So, the High Tech Act was passed in what year? And that year is 2009. All right, the next question. What's the main goal of high tech? Well, and you know, it was not to replace HIPAA. Every time I see the word HIPAA, I have to make sure I spell it right because that is like a pet peeve for everybody to make sure that HIPAA is spelled right. So if you said C, promote the adoption and meaningful use of EHRs, you were absolutely correct. All right, the next question. Which of the following is a key provision under high tech? Key provision under high tech. And you probably are like, yes, I know this answer because we just talked about it. And it was the breach notification requirement. All right, next question. High tech encourages what? What does it encourage? So, if you said B, greater transparency in health records, you are absolutely correct. Next question. What does meaningful use refer to in high tech? Meaningful use. And if you said C, using EHR to improve patient care, you are correct. Next question. Under high tech, which of the following requires a breach notification? And I'm sure you don't even have to look at these, even though you should look at all the options. But you know the answer is that lost laptop with the PHI. All right. The next question. High tech requires organizations to do what? And don't get tricked by answers. Think about the progression from HIPAA, privacy and security, to then high tech. And so if you said C, implement audit trails and security safeguards, you are correct. All right, the next question. Which office is responsible for enforcing high tech compliance? And I think earlier I mentioned the ONC, but the office that is responsible for enforcing high tech is actually OCR, the Office for Civil Rights, the OCR. Um, I I think it's important um, that you learn these like abbreviations as you see them, because you want to make sure that you can quickly answer questions, right? Because if they just give you all the abbreviations, and you don't know what they are, you could get a question wrong. I spelled out OCR here because some people think it's what's it called? Optimal character recognition, like scanning documents. But for our purposes, it is the Office for Civil Rights. And when you go to those websites, you'll actually see OCR listed. Next question. Which is most likely a compliance risk over under high tech? Okay, so what is most likely a compliance risk? And it is C, faxing records to the wrong patient. And I think I had a question. Oh, yeah. So CCS exam questions related to high tech will likely focus on. And the correct answer is privacy, security, and breaches. So while I am thinking about it, I did want to kind of differentiate OCR and ONC. So, because I actually mentioned it in a previous question. So, OCR, the Office of Civil Rights, is a part of the Department of Health and Human Services. And they have the regulatory authority for HIPAA, privacy, and security. OCR also issues guidance and interprets the rules for HIPAA, privacy, and security. And those rules are things like um, how they apply to electronic health records, personal health records, as well as health information technology. OCR has the enforcement authority to ensure compliance with HIPAA privacy and security rules. They investigate and they have the ability to impose penalties. Now, high tech enhanced the privacy rule, which included, and I think we talked about this, but I want to make sure I reiterate this again. But they extended certain requirements to business associates, right? Limiting the uses and disclosure of health information for marketing. It also prohibits the sale of PHI without authorization. Okay, ONC, the Office of National Coordinator for Health Information Technology, is charged with the development of a nationwide health information technology infrastructure that allows electronic use as well as the exchange of health information. The OCR examines and recognizes, they recommend policies and technology, again, promoting privacy and security. Okay. ONC also develops the regulation of certification of electronic health records. All right. So that is enough about that high tech. All right. And our last task is exhibit an understanding of computer assisted coding and its impact on coding. And I know a couple of you actually work with some CAC products. So, one thing I want to be very clear about, based on what we know today, computer assisted coding is not going to take over the role of coders, but it certainly will. It certainly will impact how the work is done. So, computer assisted coding, the technology, right, uses natural language processing to scan the documentation and suggest the appropriate codes. So, for example, the provider note could say chronic obstructive pulmonary disease with acute exacerbation. And the system says, oh, that's J44.1. CAC supports coding efficiency, but it does not replace the need for a coder review and evaluation. You cannot just click OK. You definitely want to um, review the documentation. CAC is designed to promote coding productivity. All right, let's continue here. So, how does the CAC work? So, CAC systems extract information directly from the documentation using NLP, natural language processing. Let me also call out that natural language processing has been around for a long time. People think it's something new, but it is definitely not new. You are seeing more and more discussion about it because technology has evolved, and so as a result, the software is evolving as well. All right. So what are some of the benefits and risk of CAC? Um, CAC has several benefits, right? Increases coder productivity by reducing that manual code look up. I know many of you who are coding today with encoders, you are kind of struggling. Hopefully, have gotten better, but you're struggling with actually looking up codes in your code book because you have been dependent on your encoder. CAC can suggest inaccurate codes if the clinical context isn't fully considered. That's why they need us. It may overcode or undercode if coders don't validate the suggestion. For example, a provider's ambiguous phrase like probable sepsis may cause the CAC to incorrectly assign a confirmed sepsis code. Now, yes, in the inpatient setting, we code conditions as though they exist, but you always want to just, review that documentation. Um, you always have to ask yourself, does the documentation clearly support the code assignment, right? If not, you need to review it further, or you may need to query the provider. Um, so despite, some of the benefits, it has some limitations, um, which I just went over, right? So it's not perfect, but every day it seems like it's getting better, or every year, I should say. So what's the coder role? Listen, CAC does not remove your accountability. Validate every suggested code against the documentation. Ensure the codes meet the official guidelines, right? And then query when we need to. It is so important to remain vigilant so that you can be compliant. So, on the CAC, I think it's important for you to understand how it actually works. So, it's used differently, right, in inpatient versus outpatient, right? So, inpatient settings, CAC is looking for that principal diagnoses, right, and procedure for that DRG. Outpatient is looking at, E&M procedures, right? In the outpatient surgery center, the CAC can help suggest the CPT code, but you still have to review the documentation. You still have to assign the appropriate modifiers, right? I will say another risk with the CAC is over reliance on the output without validation. Incorrect codes can increase audit risk and financial penalties. All right, so let's wrap up here with some questions. Question number one: what technology is used by CAC to extract codes from the documentation? And I'm sure immediately you said NLP, natural language processing. What is the primary goal of a CAC? And we know as far as we know today, is not to eliminate coders. We believe you're always going to need a human in the loop. We still need documentation. It does nothing to do with patient satisfaction. So the answer is improve coding efficiency and accuracy. Which of the following must coders still do with CAC generated codes? And I'm pretty sure we got to review and we have to validate. Review and validate them. We cannot take what they say as the final answer. A common risk of using CAC without coder insight or oversight. um, it is C, incorrect code assignment. So if you said C, you are correct. The next question: which of the following is true about CAC? Which of the following is true about CAC? And let's see what you guys are saying. And it is C, should only, or it should be used alongside a manual review. All right. CAC is useful for which of the following? And the correct answer is C. Quickly assigning suggested codes. Quickly assigning suggested codes. But the coder still has to do what? Review, review, review. Validate, validate, validate. CACs can be integrated with, and I know you guys know this answer. I feel like we talked about it earlier when we talked about encoders and groupers. And so it can be integrated into the EHR. All right, couple of more questions here. Which of the following roles is most affected by CAC technology? Which of the following roles is most affected by CAC technology? And it is the health information technician. All right. The next to last question. One limitation of CAC systems is that they. And if you said C, may generate codes without full context, you are correct. And here is the last question, and it is struggling to come up. So let's see here. The very last question. All right, here we go. Coders using CAC must be especially vigilant for. All right, and the answer is codes, suggested codes lacking documentation and support. So we have just completed domain number 5, which is on information technologies. As a reminder, I am going to go back to domain 2 and then 3. I had some additional content that I needed to ensure was included. So for the rest of the evening, I'm going to have you go back to the ICD-10 PCS questions. Again, the end result is that you will have done 200 of these. This is one of the areas that you all said that you were struggling with. And I wanted to make sure that I gave you as much practice as I possibly can. Next week, my plan is that I'm going to push you into scenarios that involve diagnoses and procedures. And June 4th will be our last day. And so I just want to make sure that I give you as much as I possibly can as we continue on this journey. So take yourself a little small break and get to opening or coding those scenarios.